Hi, I'm Tom Buchholz. I'm a radiation oncologist who practices at Scripps MD Anderson Cancer Center in San Diego. I'm also the medical director of Scripps MD Anderson Cancer Program. So radiation plays an important role for people treated with breast conservative treatment for ductal carcinoma in situ, or DCIS. A number of randomized trials have shown that the addition of whole breast radiation following lumpectomy reduces the chance of both a non-invasive or another DCIS recurrence within the same breast, or even more importantly, reduces the chance of an invasive breast recurrence. So there are some categories, namely elderly patients with very low-grade DCIS, in which you could even consider avoidance of radiation. But most patients with DCIS will be recommended to receive radiation as a component of their care. So once you decide to treat with radiation, there are a variety of secondary questions. The first is, what volume of the breast do you treat? Do you treat with a whole breast approach that was historically used in these randomized trials? Or can you take a more novel partial breast approach? And secondarily, do you treat with 5 weeks of treatment? Or can you now treat with 3 weeks of treatment, similar to the hypofractionation schedules that are used in invasive cancer? And finally, do you have to do a tumor bed boost, which is again a dose escalation just in the region of the tumor bed for those receiving whole breast radiation, and extend the treatment an additional week's worth of time? So all these again are individual trade-offs. My personal preference is I probably treat whole breast radiation more commonly than partial breast. Why? Again, that's just the parameters by which the randomized trials were based on. That DCIS has a propensity to crawl along the ductal system in a way that extends beyond that can be visualized with just mammograms alone, or even in surgical specimens. It's hard to orient the exact extent of the disease on a two-dimensional slide when it's really tracking along a three-dimensional ductal system. But clearly, I think there's sufficient data that if a patient strongly desired a partial breast approach and had favorable disease characteristics and negative surgical margins, I think that's perfectly reasonable as well. So I'm not adverse to considering a partial breast approach for such women. In addition, my preference these days is to hypofractionate or treat over a 3-week course of treatment rather than a 5-week course of treatment. We usually use a fractionation schedule that does consist of 15 fractions of whole breast radiation. And then we typically do a boost, although again, depending on the clinical scenarios. I like to put patients in higher or lower risk features according to their characteristics. Again, the size of the disease, the grade for DCIS is important, the proximity to surgical margins, and then how inconvenient or what is the cost of doing the actual extra boost treatments. And the cost could be in a couple of ways. One, it could be a real hardship to have an additional week of treatment if you're coming for a very protracted drive. And secondarily, there could be normal tissue costs too. So if someone is at higher risk of having normal tissue complication with the boost, namely, when I see this, I'm thinking of a very big post-operative seroma or requiring a very large component of resection of the breast, where I'm thinking about the long-term cosmetic outcome for the patient. And clearly the boost volume is a factor in determining whether or not that's going to add to the challenges of cosmesis moving forward during the survivorship period. So again, I try to individual based on the individual parameters of the case in point. So just to summarize, I think radiation does play an important role in DCIS. If I'm going to treat, most commonly I treat whole breast treatment. When I say whole breast treatment, when I started my training, it used to mean you had to do everything to assure that every last component of the breast was included. Now I think we're a little bit more forgiving now that we know that partial breast is an equally important approach. So if someone has a very redundant inframammary sulcus skin fold where the acute toxicity could be high and the tumor's in the upper outer quadrant, I don't have any hesitancy of shying away from the radiation dose in the inframammary sulcus. Equally important, perhaps even more important, I'm committed to never treating the heart during a left-sided DCIS case, and to put a heart block in that's well away from the tumor bed site for DCIS is clearly appropriate and warranted in the benefits of risk-benefit ratios. So in general, I usually treat with a 15 whole breast treatment followed by a 5-fraction boost. And people really tolerate it quite well and have excellent outcomes.